Thank you very much. Okay. This event was very early on in my placement, on my training. So my placement in the operating theatre, I was just 18. Couldn't believe that I was put on call so soon. How bad could this placement get? On the day I was on call, I worked a late shift and I started at 1 o'clock. Finishing shift at 8, I went to bed at 9, fully clothed, just in case. I was woken at 1 by a loud knocking on my door and I heard a voice say, "Porter!" "Ed, you're on," he said. As I opened the door, it was Jim. I knew Jim quite well. He was a regular at the local pub. I can remember that I said to him I was going into theatre, voicing my displeasure at the prospect. He had said something like, "I'm looking forward to knocking you up in the middle of the night," and I think I'd said something rude. But when I opened the door, feeling so anxious, I was really glad it was him. He knew the drill, he was really experienced. He quickly escorted me into the night and down to the night sister's office to collect the departmental keys, but they were missing. Seeing the horror on my face, Jim said reassuringly, "I guess the night cleaner has them." We went to theatre. The doors were locked. We could hear loud radio playing, but it was in darkness. I rang the doorbell. There was no answer. I banged my hand on the door. Nothing. Jim gave the door several kicks and shouted, "It's no good. We've got to find another way in." We turned quickly and ran round the side of the building, looking for open windows. In our haste, we almost bumped into Night Sister. "Nurse, why aren't you in theatre? This is a real emergency." She appeared to be unusually flustered. "Sorry, sister," I said, "the door's locked and we think the cleaner's in there and the radio's on when we've tried to knock in," but my words tumbled out. Sister just glared at me and looked at Jim and said, "Get her in there, do what you have to. I'll bring the details round," and turned on her heel. Jim moved further round the building. "Oh, I've got something," he said. Moving closer, I could see a large window with 2 sections. The top part was slightly ajar. "What do you reckon?" said Jim. "I'll give it a go," I said, "but I'll need a push." The window sill was positioned quite low. Therefore, with minimal effort, I could clamber up and push the window open wider. The sound from the radio was louder now, and Frankie Valli's "Oh, What a Night" could be clearly heard, and it matched my mood. I had a quick look. It was dark, but some of the light was filtering through, and I could see the glimmer of sink and taps, so I knew the drop was manageable. "Okay, I'm going to give it a go. But you have to give me a push." Jim pushed my feet up, unceremoniously shoved me through the window. I landed with 1 foot in the sink, and the other had found a softer landing. I had located the cleaner. The cleaner woke with a startled shout. "Oi!" It made me jump. So I staggered back into the darkness of the operating theatre corridor. I could see the door at the end of the corridor. I ran to it, saw the keys, opened the door and let Jim in, who ran straight past me and into the male changing room. There was a lot of shouting. I tried to block it out and I went to the changing room, grabbed my scrubs and shoes, and I emerged out of the changing room about the same time as Jim. "Are you going to put the lights on?" said Jim. "I don't know where they are," I said. Jim reached up, popped the lights on. He said, "There you go," and walked out. Suddenly, everyone was illuminated, And I just went straight into action. Into the anaesthetic room, checked the suction, checked the anaesthetic machine, make sure everything was okay. And somehow it calmed me to touch all the bits of equipment, made me feel better and calmer. Jim had mentioned that it was a male patient, so I found him an appropriate size endotracheal tube. And I walked through the anaesthetic room and into the theatre. I put the lights on, connected up the anaesthetic machine, checked the bobbins to see the gas flow was okay. Checked suction again. What else? I thought, what else? Oh yeah, the table. I spun round to make sure that the table was in the room. It had a mattress on it. I didn't know what table attachments I would need, but I knew that I'd need an armboard. So I put one under the table. The anaesthetist came into theatre and said, "I've seen the patient. He's very sick." He gave me a list of drugs that needed and was pleased to see that I had run through a second line. He gave me a list of drugs that he needed, and he said, "I'm going to need that and a wide bore cannula." And he said, "I'm just going to change into scrubs." And over his shoulder, he shouted back down the corridor, "Put the crash trolley in easy reach." Oh dear, I thought, this doesn't sound good. I felt the fear begin to rise. I was just positioning the crash trolley when Sister came through and asked if I'd got everything ready. And I went, "Yeah, I think so." "Right," she said, "you can have this list of what I need. I'm just going to get changed." It was a massive list. I had never seen such a list before. I didn't know how half the things were. So I've lost my place. Sister saw that I'd got everything on the trolley, and she said, "Right, just one more thing to do. Before we send for the patient, let's put the kettle on." I thought, she's gone mad. This patient is so ill. She said, "You'll learn." So she sat there with the anaesthetist and with my mug of tea clasped. She told me, and the anaesthetist told me what was wrong with the patient and what was likely to happen, so that I was mentally prepared. I sat there in stunned silence. So, as we were finishing our tea, the phone rang. Sister answered with a, "Yep, bring the patient round." The surgeon arrived, walked straight up the corridor and over his shoulder said, "I presume we've sent." Not waiting for a response, he went into the changing room. 2 more members of the surgical team came rushing through, following the surgeon, and headed towards the changing room. The patient arrived, looking very unwell. He'd been involved in a car accident. He got a number of broken ribs, and people suspected internal injuries, and he got sufficient bleeding that had put him into shock, but he was conscious. "Hello," I said. He looked at me with dazed, dark eyes. I took his hand. He was breathless and scared. "Will you be there?" he said. I nodded. "Don't worry, we'll look after you." And I was hoping that I sounded more confident than I felt. "Does my wife know I'm here?" I looked at the anaesthetist and he nodded and said, "Yeah, she's been informed." "Oh," he said, looking at me again, he said, "If I don't make it, will you?" I said, "You tell her yourself, you'll be fine." "Right," said the anaesthetist, "time to go to sleep. Think of something lovely and count to 10. Moving into theatre with the patient, the operation commenced. I learnt many things that night. Firstly, the concept of internal tamponade. Although the patient was in shock due to the amount of blood they'd lost within the peritoneal cavity, it was actually the peritoneal cavity that was giving them some protection. It was when the peritoneal cavity was open that the blood was released and it flowed over the patient and onto the floor, and even 2 suctions were insufficient, which was when the cardiac arrest happened. I was told to put out the crash call and get drapes for sister, get more swabs for sister. I didn't really see very much of the arrest, the resuscitation. I was too busy running about. I also learned that livers are tricky things to suture. And thirdly, I was so grateful that sister made us have a cup of tea. So grateful. The operation continued and concluded successfully. The patient was taken to ITU. I don't remember too much about it, except for walking back to my room in the morning. It was 7 o'clock. It was the summer of 1976 and was starting to get quite warm. I knew I wouldn't be able to sleep, so I went for a swim. That night I saw so many things. Cardiac arrest, splenectomy, peritoneal lavage, repair of liver. Reflecting back on that experience, I believe that night, my future of being a theatre nurse for the next 40 years was determined. That's what I was going to do. However, the cultural practice of being on call as normal is suspect, very suspect. It's dangerous and masks the issue of demand outstripping capacity. It pushes human capacity beyond our abilities. Mistakes during this time will always be viewed as human error and not as constructed situations. Thank you very much.
Thank you, Edwina. That was terrific. We are moving on to Laws and Deepak, who, with another wonderful title, are sharing a piece called Air of Hysteria.
You're muted.
You're muted.
Okay. Oh, that's embarrassing. 15 years ago, I was diagnosed with a rare lung condition, catamenial pneumothorax. It is a form of endometriosis that causes lung collapses. Endometriosis is a condition where tissue similar to the lining of the womb grows in other places. Endometriosis is normally found around the ovaries and fallopian tubes. My endometriosis is multi-organ. It started on my right lung. Most of my right lung is now removed. For around 10 years, I experienced apparently random bouts of minor lung collapses. In 2009, I was hospitalised with a life-threatening lung collapse, which led to surgery. During the 7-hour procedure, I developed conscious awareness during surgery. My piece, titled Air of Hysteria, is about my intraoperative awareness experience. I'm just going to take a glass of water, sorry about this. Oh. Air of Hysteria. Give me your hand. I will not let you fall. My eyes are no longer mine, disobedient. All will is called upon to open. Nothing. Artificially relaxed. I hear an alien rhythm, far removed from my much treasured chaotic dance. Too slow, too predictable. My body refuses to respond to intuitive instruction. Possession of my breath replaced. Too sweet, too pungent. I am captured, but not entirely so. Panic slopes off. Self-love kicks in, kicks off. Give me your hand. I will not let you fall.
Anesthesia is commonly mistaken as a sleep-like state. A medically induced coma is more accurate. A planned and temporary brain stem death with an unnerving dose of chemical estimations based on the Marsh model, a model using arbitrary physical factors such as weight as dosage indicators. According to leading anaesthetists and researchers, including Emory Neal Brown of Massachusetts General Hospital and Harvard Medical School, anesthesia is an accidentally accurate and poorly understood guess at controlling consciousness, memory, pain, and paralysis. Judgment is weighed rather than accurately calculated. Sometimes the Marsh model does not deliver. There are occasions when the anaesthetist is in an emergency situation and their skills, experience, and knowledge are not enough. Of course, there is also luck. Intraoperative awareness is not for the faint-hearted. It occurs more frequently amongst children, women, and those who experience high levels of what is known amongst the anesthesia community as brain chatter when conscious. Underestimation is the better end of the deal. Overestimate the dosage of anesthesia's volatile ethers, such as sevoflurane or isoflurane, propofol for nerve blockage, or the powerful pain-killing agents of opiates or ketamine, then all is finalized prematurely.
Give me your hand. I will not let you fall. External layered sounds register. High frequencies, sharp, steady, stable. Low frequencies, faint, familiar, fervent. Hissing, survival drills. Hope floating around my mind. I hear the echoes of my brain. My heart provides pace, a symphonic, sanguine fluidity, carrying fresh melodies, the diapason of life. Glassy numbers dance on Einstein's beach. Eno's Another Green World wants to run and tie my shoe. Moby's Troubling Porcelain sends me out of my mind. I took hold of your hand. You did not let me go. Okay. Thank you.
Oh. Thank you, Laws and Deepak. That was absolutely riveting. I think there is going to be a lot of discussion at the end of this panel. So the next up, we have both Annika Sani and Anna Baptista are with us, and I believe that Annika is going to present their paper, Storytelling Murmurations, Beyond Numeric Measurements to Better Patient Care.
Hi, everyone. Thank you for the introduction. I have some slides, so I'm just going to attempt to share my screen. Hopefully that works. Um, can can you see that?
Yes.
We can see the sort of collection rather than the slide. There we are. Yeah, we've got the slideshow now. Perfect.
All right. Okay, great. Okay, so I'll start. So today I'm going to be talking about storytelling murmurations beyond numeric measurements to better patient care. So just some background about myself. I'm currently a final year medical student at King's College London, and I intercalated last year at Imperial for medical humanities. And my interest in becoming a doctor started with a fascination of human biology. But I soon realized that subjects like philosophy were much better suited for describing the human psyche. And discovering medical humanities at medical school really helped me bring these two interests together, and it helped me understand people in a more holistic manner. So this project used collaborative autoethnography to look at three key time frames during my medical education. And the first was a medicine and literature module. The second was a medical humanities degree, and the third were my clinical placement years. So through my reflection, I tried to answer the question, how can medical students' personal reflections on medical humanities and education contribute to our professional identity formation and our future clinical practice? And from my analysis, the theme of storytelling emerged, and I looked at this in more detail from physician writers, readers, and patients. And I discussed how storytelling can be used as a tool for connection, catharsis, expression, and learning. So to begin with, storytelling as connection. So during my medicine and literature module, I explored works by many different physician writers, and one short story that resonated deeply with me was Bulgakov's Baptism by Rotation from his book A Country Doctor's Notebook. And this collection draws on his experiences as a newly graduated doctor in a rural Russian hospital setting in 1916 amid the Russian Revolution. And despite our differences in time, country, and political climate, I felt a profound connection with his words. So in his story, he is left to manage an obstetric emergency on his own during a night shift. And he says, "And there was I, all on my own, with a woman in agony on my hands, and I was responsible for her. I had no idea, however, what I was supposed to do to help her." The transverse lie is a wholly unfavorable position. Too true. Wholly unfavorable both for the woman and for a doctor who only qualified 6 months ago. Those 10 minutes told me more than everything I had read on obstetrics for my qualifying exams, in which I had actually passed the obstetrics paper with distinction. And his feelings of self-doubt really resonated with me, as during this period of my life, I began clinical placements for the first time, requiring me to apply scientific knowledge to clinical practice. And what made this even more challenging was that it was occurring during a global pandemic. Medical students were classified as essential workers, and we were still required to go in for placements. And as a student that had barely stepped foot in a hospital, apart from a few weeks of work experience, doing so with so much responsibility during a pandemic was definitely a step up. But despite the situation, I got on with it, and I ended up working as a COVID vaccinator that year. But just like Bulgakov, I wasn't really sure what I was doing. But despite all the challenges, putting myself in situations that were so out of my comfort zone was probably the best thing that I did for my own learning. Doctors and medical students are used to excelling due to the rigorous academic demands of medical school. But due to this culture of perfectionism, we aren't very good at discussing feelings of failure. And this perpetuates an environment where professionals suffer from imposter syndrome. By connecting with Bulgakov's story, I was able to remove the shame that I'd attached to my own feelings. And I think that sharing difficult experiences through stories really unites us all, and it humanizes the medical professional, which I think ultimately protects doctors' mental health. This leads me to storytelling as catharsis. So as part of this module, we also acted as writers, and we wrote our own short story. And I chose to write about my first work experience at 15, which was on a pediatric ward. with terminally ill patients. And experiencing all of this at such a young age definitely left me with feelings of hopelessness about the profession. And writing the story really helped me understand my feelings better. He appeared to be 3 years old, but he looked so much smaller, eaten alive by the machines around him. He probably won't get better, the doctor responded. Oh, right, yes, I see. I stumbled over my words. I felt very strange. How could he give up on a child? Medical professionals frequently encounter painful situations, and not processing these appropriately can lead to burnout. Storytelling can act as self-care, allowing doctors to release repressed emotions and better understand their own pain. And I believe that connection and catharsis are interlinked. My story's catharsis may become someone else's connection when they read it. And this leads me to storytelling as expression, which was my reflections from my year doing a medical humanities BSc program. And during this program, we focused on patient storytelling, and we analyzed narratives from online feedback platforms using research methodologies to identify areas of care that needed improvement. And my project specifically looked at patients' narratives detailing miscarriage care. Just a warning, some of these quotes and pictures are detailing miscarriages. So I understand that this is a very sensitive topic. So if you do need to take a minute, please do so. I watched a smiling woman being wheeled in on a bed, cradling her newborn. Then I turned myself sideways in the chair so I couldn't see anyone else. I'm baffled as to why I was positioned there, on the worst day of my life, waiting to have my dead baby removed from my body, listening to people laughing and joking. These quotes describe how miscarriage care is often delivered in obstetric departments alongside care received by new mothers, which understandably is incredibly distressing and traumatizing. Reading how many patients felt overlooked during their miscarriages was difficult. And without their stories, their experiences would have been lost, and impactful conclusions on improving miscarriage care wouldn't have been reached. Storytelling is medicine's currency. Patients describe their symptoms using narratives. A pregnant woman might describe tummy pain and bleeding, which doctors then diagnose as a miscarriage. However, this medicalization often strips the intimacy of the consultation, and it reduces the patient to a pathology rather than a human being with needs. Miscarriage is a sensitive experience, and to better understand these patients' needs, we really must make space for their stories. And this leads me to my final reflection: storytelling is learning. So returning to medical school after my BSc and my literature module gave me a refreshed perspective. I really began viewing each patient more holistically, considering them as individuals, not just patient X with a disease, even though this didn't necessarily benefit my scientific reasoning or exam scores. It was still really important. I also viewed myself more holistically, accepting my human moments and recognizing that feelings of doubt are common. Stepping out of my comfort zone was the best thing that I ever did for my learning. So, final thoughts. Murmurations illustrate how complex behaviors emerge from individual actions, and this emphasizes that understanding isn't solely about quantitative data, but also about the nuanced and often unquantifiable aspects of human experience. And storytelling really allows us to explore these subtleties, offering deeper insights into both personal and professional development. As medicine is deeply rooted in the sciences, our doctors, like flocks of birds, struggle to change the tune of their synchronized movements and incorporate more interdisciplinary perspectives. But clearly, storytelling has a positive impact on physicians' professional identity, as well as patient care. So the question that I've been trying to ask myself, and the one that I will leave you with, is how can we incorporate storytelling more in medical education? Thank you.
Thank you, Annika. So powerful as well. We have plenty of time. We have nearly 20 minutes for responses, questions, reflections from those online or those here in the room. So would anybody like to get us started? Joshua.
Yes.
I remember.
Thank you. So Annika, that was, I didn't get all of your speech, but it was sounded very, very profound. And you mentioned that you started at 15. Did I hear that correctly?
Yes, so prior to applying to medical school, a lot of students will get work experience. So I mean, even to make the decision to apply to medical school, most people are quite young. So around 15 to 16 was when I was doing those work experience placements.
Wow. So did anyone guide you, or did you have a mentor or maybe someone who worked, already in that to maybe help you, or could you talk to them?
Yes, well, my grandfather was a surgeon, and he was sort of the person that inspired me to go into medicine, but he was very adamant that I go and experience it myself, and see what it was truly like. So he was definitely a mentor for me, and I spoke to him after that placement experience. Um, yeah.
Did he was he maybe sort of numb to that death, or that fact of dying, or pain? Or how did he?
Yes, I would say he was. In my story, it's actually interesting that you bring that up, because in my story, towards the end of it, I talk about that phone call that I had with my grandfather, and that sort of feeling of disbelief when the doctor just casually said that, oh, this child is not going to get better. My grandfather almost repeated that, and it seemed that it was just the accepted thing, and I guess it is something that you get numb to. But I think now that I'm on the other side of it and training to become a doctor, I can sort of understand why, in a way, because while it is good to feel, you need to have a balance, I suppose, because if you feel too much, you aren't able to do your job, which is to, treat that patient with dignity and take care of them, regardless of what that care pathway looks like.
No, of course. Well, thank you.
Thank
Thanks, Joshua. Okay, we've got any other? I'm wanting, they're just, the three together have just, I don't know if it's just me, but it's opened these terrains of the unimaginable, I suppose, for me, with the mundane. And Edwina, with yours, I just got this, it was a farce. It seemed like a farce at the start. It's like, are you making this up? I mean, completely making this up. And then it's suddenly life and death. These, it's really hit me. And I'm wondering whether you're at a point with that piece or any other work, autoethnographic work, whether you've been able to share that with other health professionals and how they've responded to that kind of work, your work.
Thank you. I've shared my work with my students. A close friend, my close friend trained with me about the same time, different hospitals, but same time. My friend and I can't actually believe that we went through such a training. My students, much to my horror, also report situations of actually being unsupported and not knowing what they're doing. And a classic one of this is when you get sent for something and all the students in the classroom, oh gosh, we've done that, we've been sent for something, we don't know what we're looking for. So it's crazy, this is still continuing. But no, it was the honest truth, as far back as my memory can go. Got a hand up.
And okay, Clive? Okay, we'll come to the online after.
Yeah. Thank you both. The storytelling in the theatre and I can't remember your name. Ace, fantastic. I think you're very brave in telling your stories. What I'm really interested in is increasingly I'm supervising other colleagues who are working in, should we say, clinical areas and education, is that you come to, with your wonderful work, to this audience, and I'm always curious, now I'm supervising folks in those domains, what the reception of your work would be to those clinical audiences. Whether you feel there would be a sense of resistance, or that I get from the folks I'm supervising, that perhaps your work's not serious, like theirs, when actually it's all about theirs, and they're a bit hiding in the closet because they're quite good at telling stories anyway, but they kind of don't, because they don't see it as a genuine form of research. So your research has had a big impact on the folks that you teach, because within a teaching domain, they're the people you want to have an impact on. But we're not quite in the clinical areas where it relates to, because you've stepped out of it. So my question is, do you perceive or feel there be a resistance to this kind of work in the clinical areas that you're actually writing about?
That's interesting. So I think part of my job, part of my job is actually to go to clinical areas and engage with the clinical staff to assist the passage of the students. And they often are, I know quite a lot of them personally, I've worked in a lot of different hospitals, and they ask me what I'm doing, and they said, God, you're still studying? You retired, didn't you? And I tell them what I'm doing, and they look at me and say, that's navel gazing, isn't it? Yeah, yeah. But they all tell stories. Absolutely, all the time, every day. I don't think they take it seriously. I don't think they take seriously the impact of their stories on others. I can still remember my first ward sister telling me that I dropped custard on the floor when I was dishing out lunch, and she said, clean that up quickly. And she told me this story about how somebody was sued because somebody slipped on the custard. I never forgot it.
If you were presenting a paper on the statistical likelihood of slipping custard to their audience, they'd probably quite enjoy it.
Oh yeah, they'd love the numbers.
But you know what I mean?
Yeah. Yeah, they'd ask me, was there a significant P?
Yeah.
Thank you for that. So before we go to Kristen was up, and then Sharon, but I just wanted to hand over to Annika and Laws, or any of your colleagues, if you wanted to respond to that point that Clive made, because it maybe is relevant as well for you.
I just want to say, after my experience of waking up during surgery, I'd actually asked by Nottingham City Hospital if I wanted to sue them. And I said no. I said, I want you to learn from this. Suing would have got nowhere. No one would have benefited. And I actually got to know my anaesthetist. He checked in on me. I was in hospital for on and off over 6 weeks. And he checked in on me every day to make sure I was okay. And I was really impressed. Really impressed. Yeah.
Thanks, Laws. That's good to hear. Anna Baptista, thank you.
Yeah, just to add something about the stories being taken seriously and the educational element of this. So I'm a medical education researcher. I collaborate with medical students in these collaborative autoethnographic studies exactly because they are voices. I do find their voices powerful and usually flying under the radar. So I do believe that me as a educational researcher do have a sort of a moral duty of bringing in these stories to the surface and working with them to make them, the medical students who are willing to share their stories and make them vulnerable for others to listen to these stories and make these stories out there. Now, and in these process or throughout this process, I'm putting things out there that are less mainstream, I'm using methodologies that most of the clinicians never heard of. But more than suspicion, I see surprise. And also the fact that I keep on pushing. I keep in a particularly very positivistic scientific field, hierarchical field. I'm keeping pushing by using less mainstream methodologies, research methodologies, by bringing in stories and make them heard. I even include them in a committee somewhere so that it's heard, by including them in a report to whoever and making sure that it's there, by being a bit I wouldn't say inconvenient, but by allowing stories to have p-values, to understand student experience and to impact on something. So this is me keep on pushing and giving just a tiny bit of my experience, but sometimes it's frustrating, but it's way rewarding to be allowed into these spaces of where these conversations happen, where learning happens, and I do learn an awful lot with all the students I collaborate with.
Thanks, Anna. That's great. I'll keep on pushing, and allowing stories to have p-values will stay with me. Thank you for those. Very nice. So, Kristen.
Yeah, thank you. And hello, everyone. Thank you so much for your work. It really hit me. I'm an art therapist in the States, and I'm studying to get my PhD right now. And my sister just started her residency in general surgery. So we have not had any medical professionals in the family, and it's been quite the journey as a family to kind of learn how to support her. And it's really interesting to see the differences in our career paths, with a focus on mental health and well-being as a provider, kind of on my side, and not so much for her. And so I think the question might be more for Annika. Did I say that right? Yeah, okay.
Yes.
I was curious if you've shared your process with any of your friends or family members, like your grandfather, and how they might have received that, because I know that in my experience, just hearing stories in a much less, structured and polished way was a way for me as a family member to know more about how to support my sister. And I was also curious about your own emotional process and what it was like to be writing these stories, because I imagine sitting with some of these like traumatic moments would be difficult, but I might be wrong. So I was just kind of curious about your process, who you shared it with, how it was received, and what you learned.
Yeah, thank you for your question. I think that's a really good question. I think that while I was doing this project, I spoke more to people about these stories, whereas I think without this project, I wouldn't have done so. I think that when you're in the environment with other medical students and perhaps other people in the profession, I think that the experiences I have are not uncommon. So sharing them didn't necessarily bring anything different because everyone sort of goes through the same thing. It's almost like these difficult moments are accepted in a way because everyone has them. But I think that having these conversations and sharing them with like friends and family during this project definitely made me kind of stop and almost honor what I went through, which helped me process it. I think in particular the pandemic, I think I didn't realize how much going into placements affected me in a mental health in this sense of my mental health until after this project and speaking to it with people outside the medical professional, because all my student friends would just say that that's also what we went through, so we almost thought that it was normal. And I had a conversation with a friend recently about it, and she just said, oh, so the first time that you ever had that responsibility in a clinical placement setting was during a global pandemic when no one knew what they were doing. And I was like, yeah, that's true. That no wonder I found it so scary, because that would be scary for anyone. But I think that, yeah, we just normalize it in a way.
That's great.
Thank you.
Thank you both for that. Sharon, you've waited very patiently. Sorry to keep you waiting, but it's over to you now.
First of all, thank you for hearing all these stories, which are very realistic stories. So I come from Malta, and I'm a nurse educator, and I'm a counselor. I was the first to use autoethnography in the University of Malta. So I come from a health department. I went totally against the grain of what they were used to. And initially, I was very scared I recounted my story of misdiagnosis and then misdiagnosis of myasthenia, and then I was diagnosed with chronic fatigue syndrome. And I put it on the page. Now, for people that don't know, Malta is a very, very small island. We have one main hospital. So whatever I put on the page, it's not only identifiable, but you know who you're talking about, and so on and so forth. Going forward, as I said, I'm a nurse educator. So I join Anna's comment as where I position myself today of the moral obligation of creating a platform for students to recount that, to tell their stories. So what I am doing, I coordinate personal professional development. And what I've been doing, and that was a kickoff and set off also from autoethnography, of using art-based modalities for people to tell their stories. People might tell their stories through writing, through recounting, but also through art. So we have created this platform for students to feel safe to tell their stories. And it is about empowerment. Yesterday, there was a really good presentation about voice and noise, and give students within a hospital health setting context a voice to be heard, the power to make their voice heard, and also agency, which in a hierarchical ambience of a hospital could be very daunting. That's my take of this, and well done to all the presenters.
Thank you, Sharon. Pat, are you waiting to speak as well? Okay, over to Pat Sykes. You're on mute, Pat. We're a little bit short of time, so if you could be fairly brief, Pat, if possible, please.
Yeah, well, what I was going to say, it's an observation, and that is that doctor stories and patient stories are so popular. I mean, they're in the bestseller list, and people in England are aware of that book by, I think it's called This Is Going to Hurt or something like that, that became a television series. And all through my reading life, which began when I was about 60 odd years ago, I've been reading medical stories written by doctors, written by nurses, and then accounts of memoirs of people having medical conditions and writing about that. And then there are all these programs on the television at the moment about operations and emergency departments and things like that. Such stories are really out there. They're there in the public domain, and people really are interested in hearing them. And I mean, you know, we're talking about stories, medical stories in this academic context and making sense of them. But I think the general public makes sense of medical issues sort of naturally by going to these stories, and just an observation.
Thank you, Pat. I think we are at time, really. So I think I will just invite everybody to please show our appreciation once again. These just three really powerful, really important, really worthwhile, wonderfully presented pieces. Thank you all.